It's time to focus on seniors with Helping Seniors TV. The television show designed to make you aware of senior issues and needs, as well as to acquaint you with the resources available to help you age in place and with dignity. Now, here's your host, Joe Steckler.
I'm Joe Steckler, and welcome to Helping Seniors, the television arm of Helping Seniors of Brevard County. Our show is designed to provide you with information on how to develop your own aging and care plans. Our topic today is periodontal disease, and joining me is Dr. Lee Sheldon of Solid Bite Dental Implants. Welcome, Dr. Sheldon.
Good to be here, Joe.
Yeah, it's been a long time.
It has, but it's got, we do this well together. So let's do this one well together, too.
Well, a thing about what I like to do is show Dr. Sheldon viewers is that we both have a good time doing it. We enjoy doing it. Dr. Sheldon always has extremely valid, good, and up-to-date information on how to help us all take better care of our mouths. And that's one of the things we're going to talk about on a couple of shows I'm going to do with you, Dr. Sheldon, the importance of taking care of these things.
Yeah, that's right. That's right, because it isn't just these things anymore. We used to think it was just these things. Somehow we felt that the mouth was divorced from the rest of the body. I don't know why. Doesn't make any sense. But given all of the information we have available now, given the fact that we know that periodontal disease is related to every other disease that's been studied, it isn't just a dental problem anymore. It isn't just a gum problem anymore.
How many of our viewers watching us today, how many of them think really could believe what you just said?
I know. For some reason, I think it's because people went to medical school and people went to dental school. And for some reason, because there were two different schools, there was a separation between the two. How could there be? There's a bloodstream that goes in here. That bloodstream is affected by bacteria that hit the bloodstream. How is the bacteria going to hit the bloodstream? It's going to go right through the gums, and it's going to go into the bloodstream and affect other organs of the body. And that's what's being proven more and more and more each time it's studied. There's a relationship between gum disease and Alzheimer's disease?
I've heard that, but I just heard on my periphery of it.
Yeah, but it's true. Because if we're looking at the toxins that enter the mouth, anything that enters the mouth, and it's very easy to enter the mouth, particularly if you don't take care of your mouth or your gums, or you have an uncontrolled infection, it's going to flow from here through the bloodstream to every other part of the body.
A good example of that is that my primary care doctor wanted me, I told him I just didn't feel good. I didn't have any energy, so they prescribed a series of B12 shots. So I took the shots. They may have helped a little bit. Then after I saw him on a checkup, he said, "Are you still taking the B12?" I said, "No." He said, "I want you to take the B12, but he said instead of taking the capsules, I want you to take the liquid B12 and you put it underneath your tongue,
right? Because
it gets into your bloodstream quicker."
That's right.
So it works, and that's what I do. Yeah. I have to remember to take it every day because I can't put the liquid stuff in my pill box.
That's right.
So, Lee, we can talk all we want about gum disease, any disease known to mankind. But until we start paying more attention to it and start doing a better job of disseminating information like we do on this show about the overall effect of gum disease on the body and how it's related to everything else, we're just sort of touching the tip of the iceberg.
Well, we are. And new data has come out to show that, in fact, gum disease is a lot more prevalent than we thought it was. When I graduated from school, which was quite a few years ago now, we used to think maybe there was a 5%, 10%, 15%, 20% correlation between or disease rate, periodontal disease rate. But frankly, that was because we didn't study it very well. Recent studies that came out only in the past 2 years have shown that in the United States, 50% of the people have real periodontal disease. And I'm not talking about swelling of the gums. I'm talking about actual bone loss around the teeth. And of course, when bone loss occurs, that means it becomes a systemic, an overall problem, right, rather than just a mouth problem.
But you're raising another good point. Most often, or many times, periodontal disease is not visual. You don't see it.
No, you don't. And you're right, because people say, well, my gums don't bleed. Well, you know why? Because the disease has gone so deeply below the gum line that it isn't touched by your toothbrush anymore. It can't be touched by floss. The gums will bleed when I probe and go down to the base of the disease. If I'm measuring a periodontal pocket, which is what we do as dentists, periodontists, we all do this, hygienists. We take a probe, we measure below the gum line. There's a certain measurement that's healthy. It's the number of millimeters that we can go below the gum line before we touch some kind of attachment between the gum and the tooth. And if you get 1, 2, or 3 millimeters, that's normal. You get 4 or more, that's abnormal. You get down to 7, you've got a pretty serious disease going on.
What he's talking about, folks, is taking something and stick it down your mouth, on your gum, and when you know it hurts, he's found your problem.
There are some people who can do it painlessly, however.
Not many. Not many, Kenny.
I got to tell you, we do have the problem because we do an examination. We're placing a probe down in there, and it is an inflamed area. And you're right, if it's inflamed, it does hurt. There's a compounding pharmacy that makes up a special mouthwash that we use now, where you rinse out, and you rinse out for about 2 minutes, and this will numb the gums enough that you can do an examination in the worst periodontal condition, and it'll feel okay.
It's kind of like a shot?
It's like it's a numbing liquid.
Holy smokes.
It's a rinse.
Let's talk about our show. That we have some things we do want to talk about.
We're going to talk about some questions over here.
We've sort of beat around the bush, but talk about the different classifications of periodontal disease.
Okay.
What is it?
Okay, first is gingivitis. Now, this is what happens when you're young, your gums swell, your gums bleed. And all that is an inflammation of the gum tissue. Doesn't affect the bone, and it's totally, totally reversible. How is it reversible? All you do is brush your teeth, floss your teeth correctly, maybe get your teeth cleaned, and that gingivitis, that swelling of the gums will go away.
Okay, that's the easy one.
That's the easy one. Second is periodontitis. Now, periodontitis affects the supporting bone and the attachment between the bone and the tooth. That's when you start to get into trouble. And that means the bacteria has now migrated below the gum line, causing an inflammatory condition below the gum line, which caused the bone to separate from the teeth. If that disease isn't caught early, the teeth ultimately get loose and they come out.
Can that happen to young people as well as older people?
It does, yeah. Just like we have type 1 diabetes, for example. Okay. We have aggressive periodontitis or juvenile periodontitis, which can cause... The youngest child that I've seen in my practice is 6 years old who had periodontal disease of her permanent teeth. Now, you don't have very many permanent teeth at the age of 6.
No.
But sure enough, she was seeing a children's specialist. A children's specialist sent her to me, and we were able to keep her teeth. Oh, she's probably well into her 20s, maybe even 30s by now, and we were able to keep her teeth, and she did fine.
What tests are available to check on all this stuff? How do you do this? What do we do?
Okay, so the old tests, and they're still good, and we use those all the time, is the periodontal probe, the one we just talked about. The new test I love, because we know there's 11 different periodontal bacteria, periodontal disease causing bacteria in the mouth. That's what's been identified in the literature. 11? 11 different ones. Oh. And there's now a test called the oral DNA test. It's a brand name of a test, but okay, so be it. One of the biggest problems that we had, let me go back for a second to describe where the oral DNA test came from. Ordinarily, when you see a doctor and you have an infection, the doctor will take a cotton swab of the infection, put it on an agar plate, and grow out the bacteria in the laboratory. Well, we couldn't do that very well in the mouth. Number one, we couldn't identify the bacteria. Number two, there were only specialized labs who looked at dental bacteria. So sometimes I would have to send them up to Gainesville or sometimes to Philadelphia, and by the time they got there, the samples were dead. Yeah. So what they did was say, all right, listen, we've been doing this for years. We really haven't done this very well. What else can we do? Well, you can identify the DNA of the bacteria, and the DNA stays as DNA, whether the bacteria are alive or not. That opened up a whole new level of diagnosis for us. So if a patient has a disease that's fairly serious, fairly widespread, or a disease that I'm looking at and saying, gee, this looks more than traditional periodontal disease. All that person has to do is spit in a cup. We send it out to the lab, and a week later I find out the bacteria that's growing there, and I can prescribe the proper antibiotic in order to assist that patient in getting the disease under control. The antibiotic won't do the whole thing, but if the disease is spreading, we want to contain it. And so we can contain it with the bacteria, and then we can do our deep cleanings of the teeth, the things that we do in order to be able to save teeth. And it becomes much more effective and much more predictable. And really, predictability is what we're looking for. And we're going to talk about this later on. Diagnosis has to precede treatment, whether we're talking about dental disease or we're talking about any overall body disease. We have to diagnose first. And that's the diagnosis creates the predictability that we have.
I'm trying to keep on your shoulders. You get ahead of me today.
Yeah, I did.
Okay. But it's interesting when you talk about spitting in a cup.
Yeah.
Small story, viewer. I had a dentist that worked for me when I was executive officer on a submarine tender in the Navy. And he was a dentist in boot camp. And when you get these kids that come into the Navy from all over the United States, from all walks of life, some of them have never seen a dentist.
Yeah.
Well, in boot camp, they run the kids through just one right after the other production lines. They have two dentists in the office. They're both working like crazy. And John told me one day, he said he had this country boy sit down in the chair, and he had done some work, and he handed him a cup and told him to spit. He didn't know. He just looked at it, and John said, spit. So he did, right in front of John, instead of in the bowl.
Oh!
John says, I was flabbergasted, Joe. He says, I had never had that happen to me. But every time, if I'm talking to you and you talk about spitting in a cup, that story comes back 20 years later to think about that.
Make sure you spit in the cup.
Make sure you spit in the cup. How importantly is it that with all the work now with our x-rays and now the CT scans, how do the CT scans fit in with what we're talking about now?
CT scans are really good at looking at bone, but not necessarily looking at periodontal disease. Traditional x-rays are better. Traditional x-rays are clearer. When we're looking at fine points, and we're taking a probe, you have a narrow probe, you're not going to see that kind of differentiation in a CT scan. But when we're trying to decide whether it's more predictable to save a tooth or to extract a tooth, that's where the CT scan is really invaluable, because we're not just looking at the tooth anymore. Now the dental implants are so predictable, and they are the most predictable way of replacing teeth. We have to really look at this and decide, are we going to save the tooth, or is it worthwhile doing all the work that there is to save the tooth? Or is it better to extract the tooth and put the dental implant in? And that's where the CT scan is invaluable, because as I'm looking at things, I have to look, well, how good is the bone support below and around the tooth?
Okay.
And it may be that putting a dental implant in will be better for that patient long term than trying to save the tooth.
So what you're saying, in effect, is that it's like maybe should we spend $10 or $1?
That's right. But sometimes that $10 or $1 can end up being $100 instead of the $10. Let's assume, for example, you have a tooth that's badly broken down, and it needs a root canal, it needs a core, it needs a crown, it needs gum surgery in order to be able to make the tooth long enough to put the crown on. Now you're talking about 4 different procedures to save a tooth. Sometimes it's just not worth spending all that time and all that money to do something like that when there is something more predictable to do.
That brings up, I know of a case where a person needed a root canal, and it was a complicated thing. And they were sent to a specialist.
Endodontist. We have some great endodontists in Brevard County.
We do?
Yes, we do.
Yeah. But is it a common practice for an endodontist to charge for just to examine the tooth?
Yes.
It is?
Yeah. As a matter of fact, there are times when, I'm a periodontist, I'm a specialist. Obviously, we're in a, here, at least I think I'm in a highly trained area. But there are times when I'm not certain, and I don't have all the diagnostic tests available to me to be able to determine whether the nerve is alive or dead. And particularly when we're looking at pain and we're trying to identify where the pain is coming from, the endodontist has more sophisticated tests and a number of tests that I don't have. Okay. And so it is appropriate, and I do refer patients occasionally to an endodontist just for that reason.
Yeah. Have you ever had a root canal?
No.
have you ever had any kind of experience with pain caused by a root in your own mouth?
No, I haven't.
Okay. I can assure you it's extremely painful.
Yeah.
And it's not something that you can ignore. And taking a swab of Jack Daniels and putting it over the tooth does not really alleviate the pain.
Okay, I've never tried that either.
Well, that's an old Kentucky remedy.
Yeah.
But it doesn't deaden the pain from that.
No.
But we're talking about disease. And what are some of the things, and you use the word called modalities. What are some of these? What does that mean?
Well, modality is a method of treatment. And there are lots of different modalities of treatment, whether we're talking about heart or whether we're talking about gums or teeth or anything else. Example, traditionally in periodontal treatment, the first thing we would do would be go down below the gum line and we would clean the teeth. And then if that didn't work well enough, then we would do gum surgery. Okay, so one is deep cleaning. That's one modality. And surgery, gum surgery to resolve the problem is a second modality. Well, about 14 years ago, somebody a lot smarter than I am said, listen, when we're cleaning below the gum line, we really can't see what's going on. We know that. There are a number of tests that say that if we go down below 4 millimeters below the gum line, we're not cleaning the root thoroughly at all. There have been tests that have shown that. What if we created a little camera, just like they're using cameras to go into knees or go into gallbladders? What if we created a little camera, tiny camera, the same size as the periodontal probe, and go down into that pocket and see what's growing on the root surface? Will that make our cleaning more effective? And the answer, of course, is yes.
Gotta be yes.
Once we can see what's there, then we can get it out. And so that person who developed that camera, it's now called the perioscope, had a different name at that time, really revolutionized what we do in periodontal treatment. As soon as we got the camera, and the camera, by the way, there's a little bit of training and a little bit of
I would imagine there would be
of a learning curve to go through. But once we were able to use that camera, and it's Rebecca, my hygienist, who's been my hygienist for 30 years, really mastered the use of the perioscope. I didn't have any periodontal surgery left to do, or very, very little, for chronic periodontal disease. She was able to get the scope down, even down to 7 millimeter pockets, 9 millimeter pockets. She was able to see that bacteria and get it out, and the gums healed up. That's why I get so good at dental implants. I had nothing to do left to do in periodontal treatment.
I'll tell you, it's been 3 years since you put my implants in. But on this side, you put the implants, and we did something else on this side. But the implants that you put in my mouth, I can't tell many from. It feels so natural. My bite, I can't tell the difference from where it was 35, 40 years ago.
I'm glad.
So mine came out really good.
Good.
But we're talking about advanced heart surgery and advanced teeth care.
Yeah.
The actor John Ritter, he had a dissecting aorta.
That's right.
They didn't realize that he bled to death.
Yeah.
I had a dissecting ascending and descending aorta. They recognized it. They worked on me. By all it was right and holy, I shouldn't have made it, but I did. And the cardiosurgeon that operated on me, he explained why he thought I made it through it. A lot of it was health. A lot of it was his skill. But the guy upstairs, it wasn't ready for me.
Good.
But it's the same thing. We have to make a realization that if we're going to have successful treatment of advanced diseases and pain activators in our mouth, we're going to think about that kind of treatment the same as they do think about repairing a heart surgery, putting valves in the heart and everything else. You don't do this for $200. You don't do a heart repair for $200. So I think one of the hardest things a periodontist has had to face over the years, the amount of training, the equipment you just described. How many dentists, I don't even know if you know the answer to this, how many dentists would you guess in the state of Florida have that camera that can go down way down deep under the gum?
I think there are 3.
In the state of Florida.
Yeah.
You have one.
Yeah. And they're not that expensive either. But, they're expensive by normal terms, but by comparison with other things we spend money on, they're not that expensive. I think it's a discipline. And as a specialist, I better be able to do the advanced disciplines. That's what I want to be able to do.
You want to be able to fix the problem that comes to you.
I do, and I want to be able to fix it without being able to go to surgery. I wouldn't want to go to surgery myself. I think that.
And why did you cut my bone out?
Well, that was you.
It was me.
Yeah, sure.
You want to be able to talk about it.
Of course, yes. That was the only reason we did.
What happens when somebody's roots start showing? What do you do then?
Oh, there are lots of other things that we can do. That's a different thing. You know, we're talking about what kinds of diseases that we have. Okay, here's another disease that's not really a disease. You know, the long in the tooth look. The roots are showing. What do you do? Well, the first part of it is diagnosis again. I know it's another show, but it's still, the first part of it is diagnosis. And what we've been able to determine through a lot of different things, but the CAT scan has really brought it forward, is that we have teeth that are sometimes wider than the bone that the teeth are sitting in. So imagine that a tooth grows into bone that's very, very thin. Okay. It's essentially then pushing the gum tissue out like a balloon. Now, that may happen when we're 6 or 8 or 10 years old and the tooth grows in, everything's okay, because we can expand a little bit better when we're younger. But as that pressure continues on that gum tissue, the gum tissue finally gives way. And when the gum tissue gives way, that means that you start to see the roots that are showing. It doesn't look good. The roots are yellower than the natural teeth. Sometimes the roots are sensitive. So, and by the way, they're more prone to wear because the roots are softer than the enamel is.
Yeah.
So those are problems that occur. And so then the question is, number one, where did it come from? And so on the CT scan, we can look at the tooth in cross-section and we can see how wide the root is and how wide the bone is. So that helps us with our diagnosis. And then it helps us determine what the best treatment plan is for that patient.
At that point, can you do that process where you take some of the stuff out of a person's mouth, mix it with this other stuff you have, and put it back there and grow bone?
Yeah, actually, we're taking it out of the patient's arm, and then we're spinning it down in a centrifuge, concentrating the growth factors that come out of the platelets, out of the bloodstream. Okay. And then we mix that with whatever it is we put below the gum line in order to encourage.
Is that one of the treatments for building up the jawbone?
It is. It is a treatment for building up the jawbone. It's also a treatment for building up the gum tissue, yes. It assists in both of those areas. In terms of replacing the gum tissue, it isn't the only thing that's done, but it certainly provides an assist which makes the gum tissue growth more predictable, bone growth more predictable, because if we're dealing with narrow bone, we'd like to widen that bone out. And particularly that's important not just for seniors who I know are watching this program, but also for juniors, for kids. Because if teeth need to be orthodontically moved in an area of thin bone, there's a certain limitation that's placed on that tooth movement. But if we're able to make that bone thicker and heavier, then the teeth can be moved more comfortably and more predictably into the correct position.
Was it a source of pride to you that when you did this to me, that the bone grew so much that you had to surgically cut some of it out?
How many times have you said that on the air?
I like to say that because I like for people to know, Lee, that almost any problem we have, almost any, there's some kind of a solution or resolution to it if we seek it.
It's true.
Now, we may not always find the right answer. You know, we don't always get the right answer. But I think too many people are not willing to go to a dentist, ask a dentist difficult questions. And I'm not reluctant to do that. I think it's a sign that we can do a better job of taking care of ourselves. Because when you went back and you talked about relation to disease, the body, when I had my heart problems, that's when I became truly aware of the dangers of ingesting bacteria in my mouth that would flow through my body. Because one of the quickest paths to the heart is through the mouth down here.
That's right.
So it makes sense for us to know more. Now, everything we're talking about today, how does that relate to seniors?
You know, I think the difficulty that we have as seniors is we say, well, everything is going to go bad, and because I'm older, that's the reason I have disease. And, you know, that's not really true. If disease is allowed to sit there and fester untreated for a long period of time, then you have a chance of losing teeth. And, as we get older and older, there are fewer and fewer things that we can do and fewer things that we enjoy. But eating is one of those things. And if you have to start working around partial dentures, which fit over the gums and, block out your tongue or cover the roof of your mouth if it's a full denture and therefore you can't taste your food very well anymore, that's really a lifestyle change that's developed as a result of either the disease getting a foothold and are not getting control of it, or if the disease has got a foothold and even we did the best we could to control it, but it still went bad, we're going to a lesser lifestyle than we possibly could have. That's why dental implants have become so popular, because people want to regain their ability to chew. They want to be able to regain their ability to smile, and they don't want to have to think about it.
There's a question you wanted me to ask, but I'm going to save that for another show, because I think there's something I want to talk about in the very few seconds we have left. We're talking about gum disease, and we talked about implants, but there is something you can do to help people have sliding dentures, and you put all the sticky stuff on your gum to keep those things in there.
Yeah.
But a very simple thing is a single or maybe a double implant.
Yeah, you can put a couple of implants in, and you can reline the denture to fit right over the implants. It'll snap over the implants on the same day. And
that's such a simple, easy way to go.
It is.
And it eliminates so many things.
It is.
What else? Anything else?
I think, and I alluded to that for a second, if you have the disease, make sure you get that disease treated. And of course, I'm a periodontist. I'm going to say go to a periodontist, because we are, that's what we do. That's what we do for a living.
And your phone number will be on the screen, so I don't have to say it now. But I want to thank you, Lee. We're out of time, and thank you for being with me today.